So the question of my study was to see whether patients at low risk of thrombosis with a polycythemia vera can benefit from the therapy, with Ropeginterferon to phlebotomy and aspirin. That is the standard therapy in patients with polycythemia vera at low risk of thrombosis. We did a clinical trial and we randomized patients with a low risk PV to the standard arm, that is phlebotomy plus aspirin, versus phlebotomy, aspirin on the top of, we had Ropeginterferon. This interferon has been approved by European Medical Agency, EMA, very recently, and it's going to be used in Europe. After 1 year of treatment, we selected 100 patients who completed the entire course of 1 year. In these patients, we did an analysis, and this is called interim analysis, because after 100 of patients, that corresponds to 2/3 of patients that were pre-planned to be included in the trial, we found that this drug was able to keep the hematocrit on target, meaning that the great majority of patients were on target of hematocrit less than 45%. In about 85, 87 of these patients, as compared with 60% of patients in phlebotomy arm alone. So at the end, we decided and we concluded that this drug was able to be of benefit in these patients. Also because these patients had a less need to be phlebotomized, so that this is an important point, because iron deficiency is associated with an increased need of phlebotomy. Moreover, patients in the treatment arm, treatment with Ropeginterferon arm, were less with the symptoms that were extremely better when you treat patients with Ropeginterferon. So we concluded that also in low-risk patients with polycythemia vera, the addition to standard therapy or Ropeginterferon can benefit the great majority of patients. You know that treatment in these diseases and in other diseases should follow the guideline recommendations. Recommendations in PV are the following. You have to decide whether your patient is at a low risk for thrombosis or at high risk for thrombosis. Low risk of thrombosis are patients less than 60 years old without a prior history of events, cardiovascular events. High risk are those with the age over 60, 65, or even younger, but with a prior thrombosis. Patients with a high risk should be treated with a cytoreductive therapy. On the contrary, patients at low risk, guidelines recommend not to treat these patients with cytoreductive therapy because chemotherapy, there is a concern that chemotherapy can induce secondary cancer or leukemia. This was the reason why we tried to do a clinical trial, and we did a clinical trial with a drug that is not leukemogenic and not a cancerogenic drug, such as pegylated Ropeginterferon. The follow-up after 1 year, we documented a clear advantage for Ropeginterferon in comparison with phlebotomy alone. And the follow-up of this study will last 2 years. We completed 1 year, and the results we presented are results after 1 year of follow-up. After 2 years of follow-up, we will answer other questions that are secondary endpoint questions that include the quality of life after 2 years, quality of life in terms of remission of the disease, and also the reduction of JAK2 allele burden. We think that allele burden can be reduced by Ropeginterferon, but to answer this last question, we need 2 years of follow-up.